You good? Okay. Good morning, everyone. It's really my pleasure to introduce Grand Rounds today. This is our fourth of our chief residents giving their first medicine Grand Rounds. Dr. Amber Hertz-Tang is a graduate of the University of Wisconsin-Eau Claire, and then came to the University of Wisconsin-Madison for her medical degree, as well as staying on as a resident and has been a tremendously successful chief resident. She's moving on this summer to become a nephrology fellow, and we're very fortunate to have kept her here. She's truly a triple threat. In addition to being a phenomenal clinician, she has experience in research, several earlier research experiences, and most recently with Dr. Sandesh Parjuli in nephrology. She's already has 3 publications in press or accepted in manuscript form, and as many abstracts as well. And she's given Grand Rounds for the nephrology division in 2017. She's an active educator. She was providing instruction during medical school and as a resident in the Patient Doctor and Society small group, as well as participating in the Teaching Masters program in our residency here at the University of Wisconsin. She's also a committed volunteer early on in the Himalayan Health Exchange. She helped out with the medical school curriculum development. She's a volunteer for the Grace Clinic. She served on the Department of Medicine Climate Committee and has participated in a free clinic here in Madison as well. And she's chair of the Internal Medicine Residency Program, the Wellness Committee. Along the way, she's earned a number of awards. She received 3 scholarships during medical school, where she also was inducted in the Gold Humanism Honor Society. From our Department of Medicine, she received the Sobey Matthew Award given to the intern, who is hardworking, open-minded, supportive, selfless, and demonstrates compassion and a caring attitude for her or his patients. She's received the Kidney Star Award from the American Society of Nephrology. Our department recognized her again with the Sunday Award, recognizing the importance of the human touch in medicine. She received the Best Internal Medicine Resident Award from the medical students here, and she holds the Bridges Endowed Chief Resident position. And from a personal standpoint, it's been just a delight to work with Dr. Hertz-Tang, as well as the other 3 chief residents. They bring an energy, a passion for our patients, for our 3 missions that is invigorating. I'm tremendously pleased that Dr. Hertz-Tang will be staying on with us for training in nephrology. And please join me as we invite her to provide Grand Rounds today entitled Bottom of the Well, How Organizations Can Help Lift Up Our Burned Out Doctors. Welcome, Dr. Hertz-Tang.
If I were to tell you there is a contagious, infectious pandemic traveling across the world and the U.S. for the last 20 years, what if I told you that this pandemic is so terrible that it affects 50% of those with a major risk factor? What if I tell you that all of you have been exposed? Now, what if I tell you that I'm talking about burnout and that major risk factor is being a physician? Do you think I was just being overly dramatic, blowing things out of proportion? You don't have time to be burnout. You've never been affected by burnout. You have 105 unanswered in-basket messages, 15 clinic notes, and a kid to pick up by 4:45.
It's not loud enough and you max out the volume.
Oh.
This is the way your dress is. It's too far away from you. You need a necktie or something. So either I hate to tether you to the microphone there.
That's
but
okay.
I just want everybody to hear your important words.
Aw, thank you. Is this better? anyway. So you don't have time to be burnt out. And even if you did, what would you do about it? More yoga? The truth is, even if you are not, or have never been burned out, you have been affected by burnout. Maybe you've had to cover a call, or a busy inpatient rotation, or overflow clinic patients unexpectedly for a colleague. Or maybe you've had to deal with the chaos of having your clinic attending, your practice partner, or trusted mentor leaving the institution unexpectedly or retiring. Or maybe you're the patient of a burnt-out physician, and you've had to leave your clinic visits feeling a little unsatisfied with the care and counseling you've received. Maybe you've even noticed some errors in your labs and your prescription medications. The truth is, even if you are not or have never been burned out, you have been affected by burnout. So maybe it's time to start treating this as if it were an infectious pandemic, because it is. So no financial disclosures. I hope that by the end of this talk, you'll be able to describe the scope of physician burnout, that you'll be able to discuss why organizations should care about physician burnout, and that you'll be able to discuss how organizations can mitigate physician burnout. Let's start out by describing the scope, including being able to define it, identify who is affected and at what rates, and identify key drivers. So the term burnout was first used in the psychology literature in 1974 by Dr. Friedrich Friedenberg during his work with drug addicts. So he observed that many of his patients would stare at the end of the cigarette until it actually burnt out. But it quickly was applied to workers in a variety of industries. And now burnout is a work-related syndrome of emotional exhaustion, or the feeling of being emotionally overextended or exhausted by your work. Depersonalization, which is a feeling of an impersonal response toward the recipients of your care. And personal accomplishment, which is a feeling of competence and successful achievement in your work. Burnout actually has its own ICD code now, Z73.0 if you need it. So we can measure burnout using a variety of assessment tools. One of the most common and well-validated tools is the Maslow Burnout Inventory. You'll hear a little bit more about this later. So burnout is different from depression, and it's different from job dissatisfaction, although it's related to both of these issues. It can result in decreased quality of care, decreased patient satisfaction, and costs in terms of decreased productivity and professional effort, as well as increased physician turnover. There's also a large humanitarian cost in terms of suicide, depression, and substance and alcohol abuse. But how does burnout affect our physicians at a national level? One of the first studies looking at this at a national level was published in 2012. So burnout was measured in U.S. physicians by obtaining records from the American Medical Association master file, which is an almost completely comprehensive list of practicing physicians. They were compared to a population-based sample designed to be representative of the general population. This study showed that 45% of physicians were burnt out based on their Maslow Burnout Inventory, which is a validated tool. 38% screened positive for depression. Here's a figure from that study comparing physician specialties. As you can see, the specialties most at risk for burnout were those in the front lines of medicine, such as emergency medicine, general internal medicine, and neurology. Interestingly, general pediatrics, which is inarguably also in the front lines of medicine, seems relatively protective from burnout. Even within our own department, we see some variation in that general internal medicine is topping the list at nearly 55% rate of burnout, whereas medicine subspecialties are closer to the mean at more like 45%. A follow-up to the study was completed 3 years later, and I have the results of the U.S. physicians versus the general population control. Again, the gold bar here is the study from 2012. and the blue bar is the study from 2015. You can see that in that 3-year time period, burnout rates in the general population didn't change at all. Whereas in the 3-year time period, in the U.S. physicians, it increased by almost 11%. It's a very dramatic increase in just 3 years. So now, U.S. physicians are 20% more likely than the general population control to be burned out. Interestingly, higher levels of education are protective in the general population, but that doesn't really apply to MDs and DOs with their higher level of education. They're at risk for burnout. I'll also note that for every 1 hour increase in work per week, there's an associated increase in risk of burnout. So this 11% increase of burnout in just 3 years has been attributed to a number of areas, including possibly changes in the structure of residency, although that wouldn't affect physicians who don't work with residents, who have other practice venues, as well as meaningful use regulations for the electronic medical record adding to clerical burden of physicians. And finally, possibly changing reimbursement practices after the signing of the Affordable Care Act may be contributing also. But really, we don't quite know why the rates have gone up so quickly in such a short amount of time. Now, we've discussed what's happening at a national level. Let's now look at what's happening in our own institution. So this year, UW Health partnered with Stanford to assess our organization's burnout rates using a comprehensive assessment tool called the Provider Wellbeing Survey. This includes elements of the Maslach Burnout Inventory that I mentioned earlier, and the results were distributed to all of us earlier this year. I'd like to share them with you now. So in this first bar graph, we compare all of our Department of Medicine physicians. In the first grouping here, we see the trainees. This includes residents and fellows. You can see that our trainees have a burnout rate of 40%, which is slightly below the national benchmark at 49%. The second grouping depicts practicing attending physicians, and their burnout rate is 41%, slightly worse than the national benchmark at 39%. As a current trainee, it's the second grouping that has me concerned. Training is supposed to be hard. We've normalized the long hours and the lack of control that we have during training. But these are attending physicians. They're supposed to have made it. They're supposed to be doing exactly what they've been training for. They're supposed to be feeling fulfilled in what they're doing, and yet their burnout rates are the same as during training. The second grouping shows professional fulfillment in our Department of Medicine physicians. Again, training includes residents and fellows, and you can see that 40% of our residents and fellows are feeling professionally fulfilled, meaning 60% aren't. Again, slightly better than the national benchmark at 31%, whereas our practicing physicians are at the same rate, 40% feeling professionally fulfilled, meaning 60% aren't. Again, pretty comparable to the national benchmark at 41%. This next group is based by gender. So this is all of our female physicians, residents, fellows, and practicing attending physicians. And here, burnout is among our female doctors is significantly higher than in their male colleagues at 45% compared to 39%. This isn't just in our institution. We're seeing this nationally. So you can see that national benchmark, women throughout the nation are more likely than their male colleagues to be burnt out. And again, professional fulfillment by gender. We're seeing the same thing. Women are much less likely than their male colleagues to feel professionally fulfilled. Let's pause for a moment and reflect on this. Just as we would never be satisfied with being at the national benchmark for patient safety issues like infections from urinary tract catheters and central lines, so too we should never be satisfied with just being at the national benchmark for professional fulfillment and burnout. All of these examples are never events. So now we've reviewed the burnout data nationally and within our own institution. So what has our response been to these skyrocketing burnout rates? Physician, heal thyself. Until recently, many organizations have put the onerous of diagnosing, preventing, surviving, and recovering from burnout on the physician. Recently, there's been more focus in
diagnosing and treating burnout earlier, and in those who are already affected, in a manner of tertiary prevention. Examples of these might be things like mindfulness training or resiliency training. Now, these are effective interventions and can prevent and treat burnout, but they only truly mitigate a few of the small factors of burnout that drive burnout and do nothing to work on the organizational and national policies that are burning out so many of our doctors. This is a cultural issue. So some posit that physicians who become burnt out might not have been well suited to their career to begin with. Perhaps they had underlying mental health issues that made them more susceptible to burnout to begin with. But in fact, physicians are more likely to enter medical school with the higher quality of life, lower rates of burnout, and higher rates of engagement and empathy than the general population. But shortly into practice, our work-life satisfaction drops by 20% below the general population. Burnout rates are nearly double, and the risk of suicide is 1.5 to 2.3 times higher than the general population. And our burnout rates are increasing faster than the general population. So we enter this field with better baseline physical health, with stronger engagement and empathy than the general population. But once we're in practice, we have distressingly high levels of distress. So what is driving so many of our doctors to be burnt out? Here's some of the drivers that have been identified. They include things like workload and job demands, control and flexibility, work-life integration, social and community at work, organizational culture and values, efficiency and resources, and meaning in work. When these things fall out of balance, we are driven towards burnout. And when these things are in balance, we are driven towards engagement. Now listen up. Just as we would never define health as merely the absence of disease, so too we should never define physician well-being as merely the absence of burnout. Our physicians should be joyful and engaged to come to work. I know that's who I'd want taking care of me. So now we've had a chance to discuss the scope of burnout. Let's move on to discuss why organizations should care about physician burnout. This will include our patient safety factors, institutional costs, and humanitarian factors. First, do no harm. So while there is still a gap in the literature surrounding the link between patient safety and physician burnout, there have been large cross-sectional studies and institutional studies looking at this link. It's been shown that physicians' burnout has been associated with a double the risk of reporting a medical error, with a 17% increase in the odds of being named in a medical malpractice suit. That longer recovery times for patients who were cared for by a burnt-out physician post-hospitalization. There's also been associations between patient satisfaction and patient adherence to medical advice if they're cared for by a burnt-out physician. And studies looking at burnout in other members of the care team have showed an increase in the rate of hospital-acquired infections and an erosion of teamwork. One study showed that physician emotional exhaustion was correlated with the increased mortality in the ICU. And a Swiss study also showed an association between burnout and mortality rates. So it's quite possible that burnout is affecting patient care. Another reason that organizations should care about physician burnout relates to the incredible cost it poses to an institution. Burnout is a huge hidden financial stress on an institution. It does this in terms of decreased productivity, both clinical and academic, increased physician turnover, and then the patient-related costs that we just discussed. So burnout is associated with a decrease in productivity. In a study out of Mayo Clinic correlating burnout rates to physician payroll, each 1-point increase in the rate of burnout or decrease in professional fulfillment was associated with a 30 to 50% increase in the likelihood of a physician would reduce their personal work effort. Here's a figure from that study. As the x-axis increases, a physician is more likely to reduce their hours as independently assessed by payroll. As the y-axis increases, physician is more likely to declare an intent to leave their current practice. And we know from other studies that a physician's declaration of intent is correlated with their action in the next 2 years. You can see some of the same names that we've seen before. General internal medicine and emergency medicine, topping the list of burnout physicians, are also those most likely to cut back their hours and declare an intent to leave. Whereas general pediatrics, which was relatively protected from burnout, is less likely to reduce their hours and leave the institution, with internal medicine subspecialties being somewhere in between. In this next figure, we can see that burnout rates are, again, correlated with the intent to leave medicine in the next 2 years, with burnt out physicians far more likely than the not burnt out physicians to declare an intent. There's also an age-related correlation here, and you see that mid-career physicians are more likely to declare an intent to leave. Mid-career physicians are those in the height of their productivity in terms of grants, publications, and influence. These are also the physicians that are serving as mentors for the junior faculty. Burnout is associated with a 15% decrease in academic productivity. So we've seen that it reduces clinical productivity and academic productivity. And this is at a time when organizations need even more productivity out of our physicians due to changing reimbursement practices. So burnout is one of the largest factors determining whether a physician leaves an institution, and may as much as double the likelihood. Additionally, turnover disrupts the entire care team. It increases the likelihood of burnout in the remaining members of the team. The cost of replacing a physician who leaves to burnout is 2 to 3 times that of their annual salary, which begs the question, how much is this costing our institutions? In a study out of Stanford, they attempted to actually quantify that question. They looked at calculating the cost of recruitment, training, loss of revenue while a physician is gaining efficiency in a new system, and loss of revenue during that vacancy period. But it doesn't take into account other factors that we've talked about, including medical error, malpractice, productivity, patient satisfaction, and organizational reputation, or retention packages that may have been given out to hold on to physicians that would be leaving due to burnout. So the American Medical Association put together an online tool where you can actually calculate the cost of turnover due to burnout in your organization. I've taken a screenshot of it here. Using data from our own Department of Medicine, we can see that we have 361 physicians in our in our department. Our burnout rates are 41% across the board. I was able to obtain that our current turnover rate is about 7.2, meaning about 25 to 26 physicians are leaving every year. I left the cost of turnover at the national mean at $500,000, meaning that 7 to 8 of our colleagues and friends are leaving every year because of burnout. This is costing our department $3.8 million per year. We should also talk about the humanitarian factors that are costs to burnout. 10 to 12% of physicians have a substance use disorder, and this is related to burnout. Physicians are more than twice as likely to have suicidal ideation, and they're more likely to carry out that suicide. Men are 40% more likely than the general population to carry out a suicide, and female physicians are more than 130% more likely to carry out a suicide than the general population. Motor vehicle accidents are higher in burnt-out physicians even after correcting for fatigue. And physicians who are burnt out are more likely to suffer from divorce and difficulty with coworkers and their support networks. Many institutions are driven to action by tragedy. So this has incited a movement to further understand and characterize burnout. Now, while the objective of my talk is to talk about how organizations can prevent burnout from ever happening, I think it's worth putting in a plug for resources available for physicians in crisis. Life Matters is available 24 hours a day to provide unlimited services to UW Health employees. You can call, text, email, request a call. They even have video counseling and an online chat function. Now, this service is available to UW Health employees. So for members of the audience that are not UW Health employees, please check with your employee benefits to see what you're eligible for. I also think it's worth noting that this service is not just a crisis service. They have a lot of resources that you might find beneficial, including general counseling, financial advice, parenting advice, legal consultation, or even just help putting together a personal improvement plan. Oops, I'm sorry. So now we've had a chance to discuss the cost of burnout, including the patient safety costs, the institutional costs, and the humanitarian costs. But what does this mean as far as the big picture goes? Some of you may be familiar with the Institute of Healthcare's triple aim. That is, by reaching these three aims, an organization can maximize its productivity and optimize its performance. These include things like the patient experience, so patient quality and satisfaction, improving the health of populations, including disease burden and mortality, and the per capita cost of healthcare. It's been posited that given the costs of burnout, including the safety and financial costs, that perhaps it's time to consider adding a fourth aim to this. That might look something like this: care team well-being. Perhaps by targeting care team well-being, we can better be able to target these other three aims. Another thought is that physician burnout may actually be an indicator of an error-prone system, and that rather than assuming our burnt-out physicians are just those who are less resilient, perhaps we should consider that these physicians actually may be our most vigilant physicians and committed group with a higher standard of care, that they're being burnt out because they're trying to provide excellent care in a broken system. So monitoring physician burnout may help us to make improvements before patient care is affected and may lead to improved access to health care and to help retain our excellent primary care providers and our dedicated physicians. So we've discussed why organizations should care about physician burnout. Now let's discuss how organizations can mitigate physician burnout. So this is clearly a daunting problem, and it's no wonder that many organizations feel powerless to make an impact. But any organization that identifies a systems issue that threatens quality of care, patient satisfaction, and limits access to care would rapidly mobilize to address it. This is exactly what burnout is to our institution. So we have enough information to start acting, but how do we go about doing that? So a meta-analysis in JAMA of 2017 compared interventions targeting the individual to those that targeted organizations, and found that organizational interventions actually had a greater impact in reducing burnout. Additionally, interventions that targeted more experienced physicians and primary care providers were more effective in reducing burnout. Now, what do I mean by interventions that target the individual? These might be things like mindfulness and reflection, resiliency training, personal coping strategies, and improved communication and EHR skills, as well as the physician's choice of their practice, location, and specialty. Interventions that target the organization might look more like these: peer support programs, physician engagement in work requirements and structure, supporting flexible work schedules, reevaluating benefits and reimbursement practices and how those might be affecting physician well-being, and optimizing the electronic health record from an organizational standpoint, as well as staff support ratios. Remember this slide? So all of these drivers of burnout have individual, work unit, national, and organizational factors that influence them. Yet many of our interventions focus merely on the individual. This demonstrates that we're still thinking of burnout as an individual's problem rather than as a systems issue. So perhaps it's time to transform our thinking and start approaching burnout as a systems issue. So this is a fishbone. We use it to help organize a root cause analysis. In this scenario, burnout is our adverse event, and all of those drivers that we just saw go on the fishbone. Now, the individual physician may contribute to burnout in a small way, but clearly there are higher impact areas in which to intervene. So we can take one driver, work-life integration, and break it down further. Again, work-life integration has individual, work unit, organizational, and national factors that influence it. So the individual factors might be things like that individual's priorities and values, who they married and what their spouse does, whether they have children or dependents, and whether they or those they care for have health issues. Now, some of these factors the individual doesn't really have much control over, and they may not even be the biggest contributing factor to their burnout. So what do work unit factors look like for work-life integration? These might be things like what the call schedule is at that work unit. What is the structure of the night and weekend coverage? Is the cross coverage available for time away? And what are the expectations at that work unit? And who are the role models? And what are their priorities and values? At the organizational standpoint, this might be things like vacation policies and sick and medical leave, as well as policies surrounding part-time work and flexible scheduling and how this affects career advancement. There's also national factors in terms of requirements for licensure and maintenance and regulations that increase our clerical work. Now, while these are national factors, organizations do have a little flexibility in how they choose to handle these national factors. So this can be done individually for each of those drivers of burnout, which can help work units and organizations determine high impact and high feasibility areas in which to intervene. So we've discussed a framework for work units and organizations to identify areas that may be contributing to burnout in their physicians. But next we're going to discuss some organizational approaches to reduce burnout and promote physician engagement that have already been attempted and been shown to be successful in other institutions. These include recognizing the problem, leadership accountability, implementing targeted interventions, and reviewing compensation and incentive practices, as well as work-life integration. So we can start off by recognizing the problem. So many organizations are so focused on the external threats, things like changing reimbursement, privacy threats, quality regulations, that they overlook the internal threat right behind them. But once an organization recognizes that they may have a burnout problem, it's time to start assessing that problem. So assessment tools like the Stanford Wellbeing survey allow organizations to compare themselves to a national benchmark. So you can actually compare improvements and how your interventions have worked in your institution. So tools like the Stanford Wellbeing survey can measure multiple aspects of burnout too, using a composite of assessments. But there are shorter, inexpensive tests available as well. One of these might be the Mini-Z Burnout Survey, which is available for free on the American Medical Association's Steps Forward website. Now, this is free and easy to administer, but may not correlate with burnout scores, as well as things like the Maslach Burnout Inventory, which is available for licensure. Now, once an organization has assessed that they have a burnout problem, it's time for thoughtful dialogue with providers within it on how to intervene. So organizational leaders need to make it clear that their doors are open to dialogue about wellness from all areas of their organization. Open acknowledgement, open discussion, and open minds can establish trust for physicians and leaders to work in partnership towards solutions. Now, this can take a variety of forms, including town halls, one-on-one meetings, focus groups, newsletters, and task forces. In fact, it has to take multiple forms in order to ensure that all physicians have a voice. So the second approach leaders can take is holding themselves accountable for those they lead. Now, leadership accountability starts at selection. We need to select leaders based on their ability to listen to and engage physicians. And we can't just pick great leaders and leave them to muddle on their own. Our leaders need continued leadership development training specifically designed to help them engage physicians. And their ability to engage physicians needs to be continually assessed. So in one nationwide study, looking at how leadership affected burnout rates by asking physicians to evaluate their leaders, I actually have this leadership survey that was used. And some of the sample questions include things like, my local supervisor inspires me to do my best, empowers me to do my job, is interested in my opinion. Now, for every 1 point increase on a 60-point score for a physician's immediate supervisor, this was associated with a 3.5% decrease in the risk of burnout and a 9% increase in patient satisfaction. Consider what that means. This study shows that by targeting immediate supervisors, we can make a huge impact. If a leader improves in just 1 point in every question, the rate of burnout will decrease by 50% in those that they lead. This might mean just going from a wishy-washy, I don't disagree but don't agree that my local leader recognizes me for a job well done to a, yeah, my leader recognizes me for a job well done. That's just a 1-point increase right there. So this study determined that nearly half of the differences seen in physician satisfaction from one work unit to another, and 11% of the differences in burnout were due to leadership score. Many of the interventions targeting individuals by resiliency training or mindfulness are successful if they can decrease burnout by just a few percentage points. Surveys like this should be part of physician leaders' annual performance review. And it shouldn't matter just that a leader was able to reach certain targets. It should matter how he or she did so and what the effect on the well-being of those they lead was. Physician leaders can also work with physicians to make their activities line up with their interests. In a single-center survey of academic physicians, spending at least 20% of your time was associated with a significant decrease in burnout compared to those that spent just 5 to 10 minutes of their time doing an activity they found most meaningful. These might be things like education, administration, quality improvement, research, or, clinical care. Now, this was associated with a significantly decrease in burnout rates. 80% of the other time they can be doing needed activities, as long as 20% of the time they're doing the activity they find most meaningful. Now, if leaders take the time to obtain this information about their physicians, this can lead to activities being delegated to the physicians that find that activity the most meaningful. So this is my son's favorite toy right now. He hasn't quite figured out that each shape can only fit into a particular hole, and he often tries to cram his favorite shape into all of the different holes. Now, when we're thinking about interventions in our institution, we have to carefully consider that not all interventions can be crammed into the same hole. What works to decrease clerical burden for an internal medicine physician is going to do very little to improve the workflow of a harried radiologist. Similarly, what works in an outpatient nephrology clinic isn't necessarily going to be what works in an outpatient general internal medicine clinic. This means we need to target work units with the greatest needs and empower local work units to implement targeted interventions, and not expect a single intervention to be universally effective. If one division or work unit is doing well while another one is struggling, resources can be focused in the area with the highest opportunity for improvement. This also allows local leaders and physicians to feel engaged and empowered, rather than just a cog in a machine. The fourth approach an organization can take is to reevaluate the compensation and benefit practices. So compensation models based on productivity pose a risk to patient safety, a cost-effective care, and physician wellness by incentivizing more work and less time. But compensation models based on quality may pose benefits in terms of patient safety and cost-effectiveness, but don't do much to combat a culture that has normalized overwork. Now, salary-based models. These overcome the issues of rewarding overwork and over-ordering. However, many institutions with a salary-based model still use rewards and incentives based on productivity. Truly, a mixture of all three of these models might be best for ensuring the best well-being, patient safety, and cost-effectiveness, and different ratios may be necessary for different physicians. This requires thoughtful discussion with leadership, especially to ensure equanimity. Now, many institutions are beginning to use physician well-being as a variable in their calculations to determine physician reimbursement. Work-life integration. So, increased work hours are associated with burnout. 45% of physicians work more than 60 hours per week, compared to less than 10% in the general population. And as we said earlier, for every 1 hour increase in work per week, there's a composite increase in burnout rate. A lot of this is pajama time. Providing opportunities to reduce work effort with a compensatory decrease in salary without endangering career advancement may be helpful in mitigating physician burnout. Additionally, allowing for flexibility in schedules to allow physicians to tailor their schedules to planned life events and to professional obligations, rather than following rigid clinic schedules, can be beneficial. Organizations may actually find this kind of flexible approach to be vital in terms of recruitment and retention in the coming years. I have a little illustration to explain what I mean by flexible schedules. So this is a typical schedule for our physician in a hypothetical clinic. There's 40 patient encounters. First slot at 9, last slot at 4. But our physician wants to work at a free clinic on Mondays. He wants to take his daughter to daddy-daughter brunch on Wednesdays. And his physician spouse needs him to do daycare pickup on Fridays. But his rigid clinic schedule doesn't accommodate any of these needs, and he's thinking of just cutting back his hours totally. One study actually showed that planned life events like these can reduce the productivity of a general internal medicine division by 10%. Or his clinic can try to accommodate these needs with a more flexible schedule. Now his clinic does accommodate his needs. He's happy, has better physician well-being. His clinic is actually holding on to the same number of patient encounters and is more productive. And most importantly, his physician spouse is happy. Additionally, vacation, I certainly can't, I make this sound easy. This is not easy. It requires a flexible approach, and it affects staffing too. So if this was easy, we would all be doing it already. But it's something that's worth considering and having a conversation within the clinic. Now, additionally, vacation practices should be evaluated to make sure sufficient support is available to allow physicians to use their vacation. This means eliminating compensation practices that incentivize not using vacation. It also means creating coverage pools to allow physicians time away from their in-basket in clinics. It'd be interesting to poll the audience and see how many of you have worked on vacation, have not used vacation days, or have not scheduled needed doctor's appointments because you feel like you just can't get away. But we're not going to do that. So when talking about work-life integration, career development is important for organizations to consider. So implementing career planning with transparent conversations around work-life needs can be helpful. This might include things like supporting home task outsourcing services and avoiding after-hour meetings, which put physicians in the position in choosing between engagement and career advancement and their personal lives. It also excludes a number of physicians who may not be able to attend these after-hour meetings due to personal obligations. Organizations should also promote career advancement and opportunities for part-time physicians. Gender differences are non-existent in terms of burnout in countries like the Netherlands, where 75% of female physicians are part-time. Part-time physicians are satisfied with their jobs, provide high quality of care, and are less likely to leave an institution, meaning they're not contributing to the cost of physician turnover in terms of burnout towards an organization. So we've reviewed these 5 approaches organizations can take to reducing burnout and promoting physician engagement. But what might an organization's journey towards wellness look like? An organization might start out in the novice phase. Perhaps they are aware that they have a burnout problem. They've invested in a wellness committee, and they're beginning interventions that target the individual. As they move on towards the beginner phase, they may have invested in a peer support program. They've begun to assess the well-being in their institution in order to identify the units that are struggling. And they're beginning to consider well-being in the implementation phase of decision-making. Once an organization reaches the competent phase, they're starting to understand the financial impact of burnout, and they've provided coaching resources to their physicians. They've begun to regularly monitor burnout, and they've invested in community building and unit-level interventions rather than just those that target the individual. Once an organization is proficient, they understand organizational impact of burnout, and their wellness is being considered in all operational decisions, not just at the implementation phase. They've also begun a funded program to support physician well-being and understanding the impact of leaders on those that they lead. They've begun leadership training to improve physician engagement. And finally, they moved on from just unit-level interventions to system-level interventions. Once an organization reaches its final form, expert, well-being is influencing all of their decisions, not just being considered, but actually influencing decision-making. Leaders are holding themselves accountable for those they lead, and they've begun to research and disseminate that research, both within their organization and organizations at broad, so that all can benefit from what's being learned. And they've begun a strategic investment in order to create a culture of wellness. Remember this slide? Estimating the cost of burnout to our department, which we figured was about $3.8 million per year, and we're losing 7 to 8 of our colleagues per year to burnout. So what would be the effect if we implemented a targeted intervention in our department? Let's say that this intervention is going to cost $100,000 per year, with a 10% anticipated reduction in burnout. This means that we would be reducing the cost of physician turnover from burnout by 10%. So we would actually expect a savings of close to $380,000. Now that's 3 times over the cost of the intervention, leading to a return on investment of 278%. Once an organization is ready to consider the cost of burnout, it's able to strategically invest like this to maximize its return on investment. Now I'd like to discuss a consideration regarding this. Now this talk has been focused mainly on practicing physicians, not on other members of the care team, including allied professionals, social workers, pharmacists and nurses, and many others. Now, while improving physician well-being might have a bigger impact in terms of return on investment given the high cost of physician turnover, it's also important to consider how an intervention targeted to the well-being of one member of the care team might affect the well-being of another member of the care team. The last thing we want to do is improve physician well-being by 2%, only to worsen the well-being of our nurses by 15%. I've seen very little data in how interventions that target physician well-being affect other members of the care team. And this is a growing consideration and an important area of research as physician well-being becomes more in the forefront of our thinking and in organizational decision-making. So I tried to think of one takeaway point that you could all walk away with from this talk, but then I realized that what I want you to take away from this talk varies depending on what your role is. So for the physicians, burnout rate is high in trainees, but it isn't much better among faculty. So it's time to consider well-being now when making career decisions. This includes the well-being and priorities of those you choose for mentors, and the culture of well-being in the place you choose to work and train. What are their burnout rates? What is the organizational plan to improve it? If they don't know or don't have one, maybe it's time to consider rethinking your decisions. Now is the time to protect yourself. This includes taking advantage of wellness resources available at your institution. Prioritize activities that are meaningful and improve your well-being. Engage with program and organizational leadership. And engage within the community. This means just your work community, but also your community at large. For the physician leaders, it's time to assess well-being and target interventions in areas that need attention the most. This means collaborating with those you lead, reviewing work activities to make sure that those you lead are hitting their 20% activity for what they find most meaningful. Brainstorm on how to make schedules more flexible to account for planned activities, which may increase productivity, but also improve physician well-being. And make it clear that your mind and your door are open to new ideas. Consider undergoing annual assessment by those you lead. Remember, by improving your physician leadership, you can have a huge impact on those that you lead. And it's time to start using physician well-being as a quality marker. And then we need to disseminate what we learn. This means from one work unit to another. Perhaps other work units can benefit from what you've learned, but it also can mean to other organizations. Now, actually, I do have one takeaway point I want everyone to remember from this. Most importantly, burnout is not an individual problem. It is a systems issue. And even if you have never been burnt out, you are currently being negatively affected by burnout. So it's time to start intervening. So, I have a thank you. I'd like to thank you guys. I want to thank my mentors, my experts, my co-chiefs who got me through this year. Thank you guys. Those who helped review my talk, and my family. Here are my references. And now I'd be happy to take a few questions. Thank you.
That was outstanding and such an important topic. I'll ask you to call on the audience, and please repeat the questions.
All right, that sounds good. Dr. Rieselbach.
Edward, great presentation. And I'd be very interested in your thoughts about team care as a targeted intervention. We've been very interested in the critical geriatric workforce work, and certainly geriatricians, I think, with their enormous overload, are real candidates for burnout. And what I would be interested in knowing is whether the team care approach with the primary care physician as the quarterback of the team would have some advantage in terms of reducing the overload of responsibilities.
Yep. So the question was the role of care team, especially in geriatric populations, and how having the primary care provider as a quarterback towards the whole care team might lessen the burden on the physician and improve care of the patient. I think that's absolutely a role that we should be investigating further. I think community at work is a huge impact in physician well-being, and so I think that does have a growing role in preventing physician burnout too. Dr. Carnes.
So in the great talk, then
Thanks.
you didn't come back to the gender differences, and I'm wondering if you might add to your recommendation examination of gender pay inequity, because I think it's very stressful for women to see they're doing the same work as their male colleagues, and every study that's ever been done shows women are paid less. The JENA study in JAMA a few years ago found at the controlling for every variable in internal medicine, women physicians are making $17,000 less. So I wonder if you might comment on that.
Yeah, it's interesting how some of the main evidence I found in this talk was that the part-time work, which isn't really addressing the issue, that female physicians just need to back off in order to be happier. I think that there's, another role. Oh, I forgot to repeat the question. So the question was about gender differences in reimbursement practices and how female physicians, despite controlling for every variable, are making less money than their male colleagues, should certainly contribute to my physician well-being. So, I think that's certainly an area that needs to be looked at, too, in terms of reimbursement practices. Yeah. Oh, yes.
So, did you come across anything that there's burnout in healthcare and medicine versus other career areas where one would expect burnout, high-stress jobs, law, science, being a police person?
Yeah, so in that study comparing U.S. physicians to the to the general population, they did...
Sorry to interrupt.
Sure.
Not the general population, focusing on other careers that are stressful.
Yeah, let me repeat the question. So the question was, do other stressful careers, what are their burnout rates compared to U.S. physicians? And when we're looking at national survey data, what we did find was that education level is protective for burnout in other industries. So lawyers with a higher level of education are more protected from burnout, except for in the physician population where higher level of education is not protective of burnout. So, yeah. Oh, that's a question.
What about longitudinal data? Do we know that physicians have not always been burned out?
Yeah, so the question is, have physicians not always been burned out? And I imagine that physicians have been threatened by burnout for quite a while. So this is a relatively recent area of research where we actually are able to keep track of burnout rates. And we do know we have a little bit of longitudinal data to show that burnout rates are increasing rapidly among the physician population. In just 3 years, burnout rates went up by 11%. I imagine that there's going to be a follow-up to that study soon because we're hitting the 3-year mark again, so we'll see. But it's hard to, look back and see how burnout rates were before we were really actually measuring it. Dr. Tata.
I really appreciated your whole talk, in particular the slide that looked at organizations moving from novice status in addressing this to expert
Yeah, so the question was about the organization's journey towards wellness and what is the rate of moving from, the novice phase towards the expert phase, as well as how do organizations begin to think of well-being in all of their decision making. So certainly important. I don't know that there's a lot of data about the rate at which organizations move. This is all still pretty recent in the literature. I know that it's not as stair-steppy as I made it appear, in that organizations may have elements of the novice phase and elements of the competent phase. So it's not a straightforward linear progression. In terms of how to make well-being considered in all decision-making, part of what can be beneficial is actually having a well-being officer whose job it is to consider well-being in all decision-making and to advocate for that in an organization. Dr. Jamali.
Fantastic. Great presentation. Thank you for coming to nephrology where there is no burnout.
I was considering that in all my decision-making.
One question for you. These are some of the front runners in terms of publications that you presented, for instance, Mayo Clinic or Stanford. How do we compare to those, and what are the overall rates of burnout in those institutions that have been working on this for years?
Yeah. No, that's an interesting question. So the question was, how do these forefront thinkers of burnout, like Stanford and Mayo Clinic, compare to our organization in terms of their burnout rates? So I think Mayo Clinic does have a little jump on most organizations, in that they have some of these leading experts that are doing all of these studies. And interestingly, during the time when physician burnout was increasing across the population, 11% in just 3 years, Mayo Clinic's burnout rates were actually decreasing during that time, and part of it's because they were a little further along on that step towards well-being. So we are seeing that Mayo Clinic's burnout rates are lower than the national population, and a lot of their data is coming from there, so I think it's worth exploring. Dr. Schulk.
My question is, have there been studies of those who are burned out at some point, get a profile of what the components are that cause them, or at least prevent them from being burned out?
Yeah, that's an excellent question. So it's looking at physicians who are not burnt out and what characteristics within that physician or in the organization in which they work are protective against burnout. I think that's certainly a great area of study. We know a lot of the drivers of burnout, and so when from an organizational standpoint, but things that can be protective for an individual. I think it's tricky because, again, you have to remember that burnout's not an individual's problem, so it can be a systems issue. So there's a lot of factors that affect whether a physician is burnt out. Part of it is where they're choosing to work, and part of it is also their individual factors, like their priorities and values. So I think there's some research into that, but certainly more is needed.
We're going to have to hold on the questions. I do want to comment this is a tremendously important issue. As you all may know, part of our strategic plan going forward is a focus on wellness for all members of the Department of Medicine community. Identification of the issue is one thing, but addressing the problem is the next challenge. But we're completely engaged and pledging to address this. With that, I want to thank Dr. Hertz-Tang for just presenting an outstanding grand rounds.
Thank you very much.